Welcome everyone to today's webinar. I am Molly Gamble, Editor-in-Chief of Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. We will be sending a copy of the webinar recording to all registrants within a week following the webinar. If you would like to receive the presentation slides, please email providermarket@teledoc.com. At this time, I want to thank today's webinar sponsor, Teledoc, and introduce our presenter. Dr. Alan Roga serves as President of the Provider Division for Teledoc. He has full P&L responsibility for the strategic direction and management of Teledoc services offered to hospitals, health systems, retail clinics, and physician groups. Dr. Roga was founder and Chief Executive Officer of Stat Doctors, a national telehealth company serving individual member patients through agreements with organizations, including hospitals and health systems. He led Stat Doctors from its inception in 2009 to its acquisition by Teledoc in 2015. An emergency medicine physician, Dr. Roga is a fellow of the American College of Emergency Medicine and a diplomat of the American Board of Emergency Medicine. Dr. Roga, I'll now turn the floor over to you to begin today's webinar.
Thank you very much, Molly, and good morning or afternoon, everybody, depending on your time zones. Pleasure to have you today, and really excited to present our findings. So we did a similar presentation a few years back on our first 1 million visits, and now are able to afford insights into our journey from 1 million to 3 million visits, which is a unique opportunity. It allows everybody on the line really to understand what's going on in the consumer telehealth industry, and having such a large body of encounters really allows us to have great data. So really excited to share our information with you all, and we will go ahead and get started. As Molly indicated, I do run the provider division at Teledoc. I am an emergency physician by training, have been a department chairman, and have been in this space now for about 8 years, which I've greatly enjoyed. It's a lot of fun. It's a great opportunity to provide outstanding, high quality and high value patient care. And I commend everybody for being on the line and the webinar and learning about it. What we're going to do today in our agenda is essentially talk a little bit about Teledoc, just to give you some background on the company and how we've gotten to 3 million encounters. Review our 10 lessons learned, both sort of a compare and contrast as to how the market has evolved. We will go into a detailed review of the 10 lessons and then head into the Q&A session. So with that, we'll go ahead and get started. A little bit about Teledoc, just to give you some background on the company for those who may or may not know about us. So Teledoc is the first and largest of the modern day telehealth companies. Company has been operational since 2005 as a venture-backed company. We went public on the New York Stock Exchange in July of 2015 and had a very successful IPO, and are the market leader by any metric out there. What we do at the end of the day is connect patients to providers through mobile, internet, or phone, and either connect them to our network of providers, or in the case of many hospital and health system and provider clients, their network of providers, or a combination of both. We work in 3 main markets. We work with employers, insurance carriers, and hospital systems. All totaled, we have over 10,000 clients and touch a little over 22 million members. Our clients range from 300 of the Fortune 1000, over 300, 35 national payers. And in the provider segment, our division, which is predominantly hospital and health system clients, over 200 hospitals that we serve, which is the fastest growing segment of the company. Our provider network, when we connect patients to our provider network provides general medical care, behavioral health, dermatology, and sexual health as product features, and we'll talk about our provider network today, and provide outstanding care. 95% patient satisfaction, 10-minute mean response time, and we are seeing over 5,000 patients a day now. As a frame of reference, we have projected to do 1.4 to 1.5 million acute care encounters, and that is when we are providing care, not necessarily counting when our hospital clients may be providing care to their patients, but in our world, about 1.4 to 1.5 million general medical encounters. As a frame of reference, that's historically been about 75% of the addressable market in today's status, 5 times more than the next largest competitor, and 10 times more than the second largest, and 3 times all the other competitors combined. So again, just conveying our depth and breadth as a company. We've talked a lot, or a little bit, about different clients and many well-branded entities, Dell, B of A, Costco, strong relationship with Aetna. But as there are a lot of hospital and health system organizations on the line, I think what's important to convey is that we do operate a dedicated team that's focused solely on the provider market. And what that does is allows us subject matter expertise and be better able to meet our clients' needs. So it's not news to us that electronic health record integration and video and features that make for a great provider experience as well are very relevant to this audience. And having dedicated resources really allows us to better able to meet our clients' needs in that capacity. At the core of our offering also is a software as a service model, which has earned the exclusive endorsement of the American Hospital Association for our technology, which we're very proud of. So at the end of the day, we are looking to build your business and brand. And we surround it with all the core Teladoc capabilities. So I will cease on the Teladoc credentialing and now head over predominantly to our lessons learned. So we did this presentation in early 2016. And having been in the space myself for about 8 years now, again, I've seen the market evolve from the employer space. So it was very firmly made in the employer space. Then we started to have positive outcomes, good experiences, good satisfaction, savings, health plan savings, then moved to the health plan market. And now we're seeing it squarely in the provider market. So you're seeing the market evolve. When we did an analysis of our first 1 million visits, a lot of our data and what we presented previously on the first 1 million visits, I would say were predominantly operationally focused. It was around the typical demographics, safety profiles, usage patterns, and other market reflections. Now, as we've progressed very quickly from 1 million to now 3 million encounters, we've learned some great lessons. So we found areas of consistency. So yes, telehealth is still very safe. We're seeing regulatory improvement and the demographics really being very consistent. But what's interesting is really on the purple, the bottom half of the slide, of some new learnings, which really reflect market evolution, technological advances, and really how healthcare has evolved from looking at improving outcomes with technology, seeing how this market is expanding and how the markets are converging. So we'll go in detail through these 10 lessons. And I think it should be an exciting discussion. So as we start, it always starts with safety. So lesson 1 is telehealth continues to be safe and effective. So as you look at the market, and we've done 3 million visits, and it is now even more safe than it was at 1 million. It was safe at 1 million, now 3 million, it's even safer. And the question would be how? Really, how did this occur? And it starts in 3 areas. It starts with education, then it goes to oversight and monitoring and corrections. So as an example, how we have structured things. Going on the right side of the slide, we have developed over 100 proprietary telehealth guidelines. So early in the company's founding and what continues to go on in an active base in Teladoc, we've looked at all the literature and created guidelines around the safe practice of telehealth, and always contemplating that the patient and provider are not in the same room, right? This is a virtual encounter. So we developed these guidelines and educated our provider network extensively on it. Then we have ongoing monitoring at the board level. So Senator Bill Frist, who, as a retired cardiovascular surgeon, chairs our patient safety and quality subcommittee. Chief medical officers, medical directors, quality directors, all reports go to the subcommittee and at the board level. So there's ongoing monitoring and oversight, and then intervention. So 98,000 charts have been reviewed this year. We have 10% chart review of all of the charts. Back to day one, 100% of charts are reviewed for every new physician, and that's gained us NCQA certification 3 times with a 100% score. So the results, that's the infrastructure that you build to have a safe program. And the results, which show again that it's been safe, no malpractice claims. So as a frame of reference, at 3 million visits, if we were a typical primary care practice, we would have been named about 51 times at this point, with an average indemnity that would be about $10 million. So incredible, thankful, no malpractice claims. Our net promoter score of 71. For those who aren't familiar with net promoter scores, that is an excellent number. So Apple, Amazon are in the high 60s, low 70s. Your average bank is in the 30 to 40 range, and your average primary care physician is in the single digit. Practice, not physician, but the practice is in the single digits. So 71 is an exceptionally high net promoter score. Patient stats, probably very familiar with everybody on the line, so 95% would recommend to use it again. The reason why patients aren't satisfied, very similar at times, I should say, very similar to what you all on the line probably experienced, which is they thought they wanted and needed an antibiotic, and they didn't get it. And we'll talk a lot about prescribing patterns on one of our lessons, but that's overwhelmingly the number one dissatisfier, but at 95%, very high, and 92% resolution rate. What's also interesting, in addition to now 3 million visits showing safe, effective, no malpractice claims, great outcomes, is that we're able to do more in a very safe way as we've expanded into dermatology, behavioral health, and other segments. So always starts with safety. Very happy that we can still announce that we've continued to do so. Lesson number 2 is around the regulatory aspects. So the regulations have now shifted towards expanding telehealth. And telehealth and the consumer side, well chronicled a lot of the prior issues around medical boards and states and sort of unsure what the guidelines were. I would say 8 years ago when I had first started in this space, every month there was a different medical board looking to make sure that the patients of their state were getting safe, effective care, appropriately so. And the guidelines hadn't been updated. More importantly, the guidelines hadn't matched the advances in technology. So even dating back to, and the good news is this is way, way better. I mean, we're in a completely different environment right now. So if we look at the maps, and this is really focused around prescribing laws, in 2015, there were 20 states that were enacting positive change in their guidelines on the regulatory aspect. And now if you look at how Teladoc is operating in 2017, we operate in every state. A great example is Texas. We've had well-chronicled interactions with the Texas Medical Board, and now in partnership, Texas has great guidelines and great legislation and operating well there. So it's a prime example of how working collaboration and educating, and again, now having 3 million visits with safety and encounters, can give a great deal of comfort to the medical board. So prescribing, much, much better than we've ever seen. As we now shift towards federal and state legislation, it's really towards promoting and enhancing telehealth. So Medicare Advantage reimbursement, really, and a lot of these are focused at risk dollars. So the Congressional Budget Office has scored telemedicine as a cost savings. And this is a great accomplishment. It's the first time it's ever scored as savings in any environment. These findings now allow MA plans to incorporate telemedicine in their bids, would yield about $80 million in savings over 10 years, which is a very positive development. But equally as important, the discussion has always been, show us the data on savings and we'll enact legislation that supports it. And you can't really get the data until you have an opportunity to service patients. So what's been great about this is that it now allows us data to quantify it, and also feeds into some of the MA wellness exams and other things that people are looking for with their telehealth programs. So MA, very positive. Chronic Care Act has gotten attention recently, so that's a Senate bill. It's passed unanimously. It has three components: telehealth in an ACO environment, coverage for dialysis patients, and then also MA plans to include telehealth service in their annual bids for 2019 and 2020. This will create incentive plans and new opportunities. It's now moved into the House. The House also has a similar bill that speaks positively on MA. So while we can't predict what will happen, the good part is both the House and the Senate have bills that have positive language around Medicare Advantage reimbursements. So that should speak well for something getting passed. Other things that are helping promote telehealth, so multi-state compacts. I'd say this is a good initial step. So there are states that are participating in multi-state compacts, as probably a lot of the folks on the line are aware at this stage, but telehealth challenges the state guidelines because you're not necessarily physically present, you're practicing remotely. So states that participate in multi-state compacts can actually have increased efficiency, so cut down on paperwork and reduce administrative burdens. It's a good initial step. The challenge is it doesn't solve any of the costs, so it still costs money to be licensed in states, and the regulatory guidelines, you still have to be aware of what that state's regs are indicating. So good initial step, still have a long way to go. And the next important one I think is around parity laws, which is worthwhile for us to spend a few minutes on. So I think parity has unfortunately become overstated and confused on what this means in the industry. So I would say there's really two things around parity. There's coverage parity and then there's payment parity. And both of those things are different. So on the coverage parity, right? Coverage parity basically, and there are about 34 states, I believe, that are saying to the payers, do not refuse payment for telemedicine just because it occurred through telemedicine. However, whatever those terms of payment are still in the contract. Then there's coverage parity, which there are payment parity, where there are 3 states that actually have strict payment parity, which means that telehealth should be paid and reimbursed at the same as an in-person exam. So coverage parity, payers like that, because ultimately that's the payer and provider negotiating, and that language basically is don't refuse payment. Hospitals and providers typically want payment parity, right? You want to make sure that I have a visit, it's getting paid and reimbursed through the traditional mechanisms that we're used to. And then the other states are silent, so they have no language in their regs. So there are a lot of hospitals and providers that come to us saying, hey, our state has parity laws, we want to do telehealth programs. And we have to explain that, really there's only a few states that have strict payment parity, and the rest is up to you to negotiate with your payers. I'd also segue for 1 minute and let everybody have an understanding of how revenue is typically generated in consumer telehealth programs. So there's 3 buckets. The first, I would say, is through self-funded employers and health plan sponsors. So Teladoc will do approximately $230 million in revenue this year. A lot of that revenue comes from self-funded employers and from whoever is the plan sponsor in the program, whether it's a health plan that has a bulk of lives, but there's fees generated by those at-risk lives. The second is fee-for-service models. So there are lots of provider organizations, $49. People are putting their credit card down and getting a telehealth encounter, and that's a self-pay mechanism. And the third is really around this one, which is payment parity/parity, which is commercial reimbursement through traditional payers. Patients are coming in as a retail model, putting down whatever their insurance plan is, and claims are getting adjudicated. That last one is by far the minority in the United States. It is a slow space. So Teladoc does lots and lots of revenue. The bulk is in plan sponsors and at some level, minor level retail programs through a plan sponsor of some sort. That last area is where providers focus on. There's still work to be done there, and I still think that's another 18 months away. So a lot on regs shifted into reimbursement, but I think also important points for everybody to know about. Okay. So third lesson is consumers are driving the telehealth entry points. When we presented this about a year and a half ago, we basically talked about patients need access, mobile, internet, or phone. You need to provide all of them so that you can drive adoption. What's interesting learning now is consumers are now driving and demanding their entry points to access care. So, and again, we have mobile, internet, or phone, and if you look at some of the icons here, and this is year to date, so call center requests in the upper right, 426,000 call centers, a request, 251,000 visits have come through the web, and then going to the upper left, we've had 375,000 mobile app downloads year to date. What we've seen transition, which is probably not a surprise to folks on the line, that 19% less is coming from the browser. We're now seeing upwards of 70% mobile engagement. And what's also interesting and this is predominantly general medical encounters, 25% of those who use the service more than once, the second time they choose a different access point. So consumer wants access and entry on their terms. Now, the other thing we're seeing is it's somewhat use case dependent. So if you shift your eyes to the BetterHelp, which is really our behavioral health offering, for behavioral health, consumers are actually fairly comfortable texting their providers. So they've done over 5 million asynchronous text encounters with behavioral health specialists, and they're driving their access points to that modality as opposed to requiring video or telephonic or web-enabled encounters. Text works very well in this market, and consumers are driving it. And then if we go to the bottom of the dial, in the provider segment, which is, again, a lot of the folks on the line, video is often requested. So provider organizations want to see their patients. We do a lot of video in the provider market. 89% of all the encounters are video. That is in contrast to employers and payers who are somewhat less paternalistic about how they want their employees to engage. So what we have seen is the more restrictive you make it, you have the effects of the consumer wanting different access points. So just as information for providers, as we mandate video, sometimes that leads to less usage. Of course, that's an organizational decision, but the more open we make it, the more access we get. And what we're seeing overall, as I said, is trend is towards mobile, less so from desktop and landline. What is an interesting lesson is this one. I thought this was very interesting, which is the patient demographics have really not changed in the last few years. So as we have seen the number of people that we touch significantly increased to over 22 million people, and we've gone from 1 million to 3 million, and the age groups have increased and the user profiles have increased. Really, the typical user is exactly the same. At 1 million visits, it was a 36-year-old female. At 3 million visits, it's a 36-year-old female. So if you look at our average age, those are the layouts. Still 15% of our encounters are pediatrics. As you go to the right side, you could see about 65% of the patients are female. When we previously did this analysis, 44% of all the patients have a comorbidity. And then if you look at the visit trends on the lower left, these mirror an ER and urgent care usage pattern. So starts ramping up around 9 a.m., goes down around 11 p.m., is slowed during the wee hours of the morning, weekends and holidays typically higher than weekdays. So this very much mirrors an acute care pattern. And by the way, the data confirms what we see from the CDC, as the female is typically the head of household and the main decision maker when it comes specifically to healthcare. And the other thing that was interesting, though, is turning your attention to the lower right-hand corner, 92% choose on-demand visits. So we offer scheduled and on-demand visits, right? And if you say, do you want to be seen in a half hour? No, I want to be seen now. Do you want to be seen an hour? No, I want to be seen now. So the overwhelming majority of people want to be seen when they're ready to be seen as opposed to a scheduled visit. And why this data is important, so understanding that a 36-year-old female who wants on-demand care is the main user profile in this market, despite the fact that we've done much more visits, despite the fact that company has tremendously grown, is really key as you're thinking through your marketing campaigns and how you're going to engage that user. Going to lesson 5. So the value of telehealth is no longer in question, and specifically as an employee benefits program, which I think is a powerful statement for us to make. So when we did this presentation about a year and a half ago, we presented that Teladoc had saved our clients nearly $387 million in savings. And we now have multiple studies that are validating very similar data. So as you can see from T-Mobile, Penske, Lineco, or the Veracity study, as an employee benefit solution, there is tremendous savings here, which is often, by the way, one of the first use cases that a lot of our hospital clients like to start with, because they're often large self-funded employers. If you look at the data on the bottom, this is from a group called Veracity Analytics. So Veracity was a third party. We were blinded to this data. And what we found was, and look at the right side of the slide where the trend was pre-implementation of Teladoc, and then the dotted line is post-implementation Teladoc. You can see a statistically significant difference whereby the overall per member per month costs reduced post-implementation of Teladoc. And that was to the tune of $21 per member per month, which for those folks who aren't necessarily familiar with it, that's massive savings for an employer. Your typical benefits program, if it's $1 to $2 per member per month, that's substantial. We've done these sort of case studies numerous times. Now, actually, what we found in the last Veracity study was $472 of savings per encounter. And I would say those findings are unique to us. Our abilities to drive adoption, engagement, and usage of the program. So great savings here, and I'm proud to say the value has been validated by multiple studies at this point. Okay, so I think on our first half, a lot was looking at operational data and where we compared and contrasted in the 2016, and now there's some really cool findings I think that are out there. So lesson 6, I would say, is around operational data and really that configurable technology with the support matter. And it matters a lot. So I would say that this is probably the second biggest mistake I see or we see specifically with hospital and health systems clients, which is underestimating operational support. We previously had spoken about the importance of configurable technology. So lots of clients wanted configurations and to make sure the software matched the use flow, and that really met the market needs. What we're now finding in addition to that is operational support with that configurational technology is a must. And really why? Because it's very important to move past encounter level thinking, just patient and provider one-on-one, and to start think system level. And it's very typical, especially in the hospital and health system space, to have what I would call the 3 levels of thinking. The first layer is, I have patients, I have providers, I just need a video solution to see them, and I've got a telehealth program. And a lot of systems start that way. Then they realize, where are you going to document and how are you going to integrate into your EHR, and are you going to bill and submit claims and take in eligibility files? And then they realize, well, I need a platform. And then after they have a platform, you start thinking through, well, how are you going to do technical support 24/7? And what happens if a patient can't log in, or a provider can't log in, or the pharmacy closed at 10 o'clock and the prescription is waiting there? How are you going to reroute it? And that's where that operational support really matters. 3 things to have a successful telehealth program for everybody on the line. You need to have a marketing program. So what are my use cases? Who's my target? Who's my market? How I'm going to engage them, and how I'm going to drive adoption. There needs to be software in lieu of a building to provide a great encounter. And then there needs to be a provider strategy. Who are my providers? How are they credentialed? What types of people I'm going to have out there? And all of that requires operational support. So as you look at some of these things, and these are just examples of things that we've done. So at Teladoc, we've actually built a 75,000 square foot operations center in Dallas, Texas. that houses an army of people 24/7 to make sure that patients are having a great experience at all times. So going back sort of across the slide on the private label software, there's about 300 configurations per instance. Every one of our clients get their own instance. So it builds their business and brand, and their data is segregated, but also those configurations match their look and feel and their operational needs. 99% of our clients will actually use our network in some capability and capacity, and that was pretty interesting to us. So especially on the provider side, where you have lots of doctors, for general medical care, we find most organizations will want to use our general medical care physicians. That's in contrast to post-surgical care, where it'd be their surgeon seeing their patients, and that's not a service that we would provide. But that's very typical of what we see, where general medical care is at some level being provided by the Teladoc network. Workflow integration, so 98% prescriptions are prescribed electronically. And you might ask, well, why is that not 100%? Because at some level, there is the small pharmacy in rural America that may not have e-prescribe or be on the SureScripts network. And as we talked about before, at some point, there is a patient showing up in a pharmacy that's closed and wants their prescription at 2 a.m. and how do you get it rerouted? Billing and claims, those are not typos, so 17 million processed daily. And then engagement marketing. So again, 3 things for a successful program: marketing, technology, and provider networks. On the marketing side, we've done over 33 million pieces, over 10 million direct marketing pieces, and 20+ million digital marketing assets. And that doesn't even get into all the other things that we've done. This is so that you can do telehealth at scale. And what we find, and really the learnings as we've gone from 1 million to 3 million, is there are breakpoints in a typical telehealth program. And as many, especially provider clients on the line, are starting their programs, you will have logical breakpoints as your programs evolve. So they are around when you see your first patient, when you get to your first 30, and then when you start seeing 100 a day, the systems that you have in place tend to not scale. And we've figured that out for you. So for those interested, we host tours there on a regular basis, and would encourage you to reach out if you'd like to see how we really do telehealth at scale. So this is one of the slides that I really like, and it speaks to how technology can improve outcomes, which I think that's an important lesson, right? We started with safety, we've done lots of visits, and very, very safe, but the questions early on were, is telehealth safe? And in some ways now, what I think is fun is that we can say, not only is it safe, but you can use technology to improve outcomes and drive towards clinical best practices. And here are just a couple of examples, which as a clinician, I think this is a great slide and a lot of fun to talk about. So there was an article published in a British medical journal that spoke about concerns with corticosteroid use for short-term steroids. That, you know, it can show sepsis and embolisms and increased fractures and things that can cause problems for patients. And corticosteroids are often prescribed or in acute respiratory infections. So we took a look at our data. And on the right-hand side, you could see what our data looked like. And there's an unpublished review from JAMA, which is coming out shortly, that showed 11% is probably the right number for ARI in primary care practices. So we looked at our data, and we looked at April. We saw we were above it. So the purple circle there is April. And then if you go to the left hand of the slide, you can see this is what our data looked like. And it's all over the board, right? We've got people who are well above 11%. We have people who are well below 11%. So we educated our providers. We said, hey, there's data out there. We technologically put some enhancements in. We scaled our guidelines. We scaled our training. And in August, just a few short months later, you can see the majority of people were at or below our 11% threshold. The one outlier there was a new provider, which we educated on. And what's also interesting is we have a lot of control over our network. So if there are providers where we have concerns over, we're able to simply just shut them off the platform, and they're not seeing patients, as opposed to provider organizations that often have to go through credentialing processes and a more elaborate program. We're able to more tightly control the network. If you look back to the right hand of the slide, you could see that we're now averaging about 5%. So, we're now getting towards what we think are best practice levels for corticosteroids, which is a newer thing to look at ARI, but I think shows a great power of how technology can drive outcomes. Other things that we know are important, so if you look at the bottom of the slide now, prescribing rates, we understand it's important. There's been a lot of discussion around it in telehealth. It's important in quality metrics and payers and payment metrics, and we've worked hard on this. So our antibiotic prescribing rate for ARI, it runs about 10% below brick and mortar. And we've made that journey over 3 years to intentionally make sure our providers understood where they're most appropriate. So we've made great success there. On medication reactions, another area where technology can help your outcomes. So we are able to convey medication reactions through our use of our e-prescribe programs and through technology. Now with greater integration from SureScripts, we're actually able in the near future to pull data into the platform so that it's not only information that we've gotten from the patient or from the EHR we've integrated with, but from exogenous sources, so that we can greater increase the safety profiles, and docs will have medical history outside of just what's on the platform. And then on broad spectrum antibiotics, we run about 2% bricks and mortar as well. So why I like this slide is because not only can we show that it's safe, but we can actually show that we're able to use the technology to drive the right outcomes towards best practice and improving the safety profile. So lesson 8 is really around the provider market evolution. So telehealth in the provider market is rapidly expanding. Again, this started firmly in the employer space for consumer telehealth, migrated to the payer space, and now is very much so in the provider space. In fact, as I indicated earlier, it's the fastest growing segment proportionally inside of Teladoc. And as we look at that evolution, what we've learned is I think it's really hard for provider organizations to look at the market, and you've got to learn from vendors like ourselves. And there wasn't really a lot of benchmark data out there. So what we did is, these are summary findings from our hospital and health system benchmark survey. So we surveyed over 180 hospital executives about their telehealth programs, and we're actually going to do this survey again. Anybody on the line, by the way, who would like a copy of the survey, feel free to email the link provided earlier, and at the end of the presentation, we're happy to give you a copy of it. What we found on that survey was 76% of hospitals either have or will be implementing a consumer telehealth program by December of next year. And the ones that have it, 69% are expanding their programs. And this is great. And what are the two main reasons for this, and why is this market really heating up? If you look at the market dynamics, so you have systems under intense pressure to reduce their operating costs. You have lack of providers, and really have payment reform and new payment methodologies. What you're seeing now also is greater connection through electronic health records than we've ever seen, and massive consolidation. All of those things unlock the potential for telehealth in hospital markets. And the two main drivers and two main reasons why most systems will really seek out a program are to help manage their financial risk, or they believe they have either a first mover advantage in their market, or they're responding to a competitive threat from a competitor who's launched a telehealth program. So that's why you're seeing the 76 and 69% as reflections of how is this market really increasing. Other things to share with you on insights. So how long have they been in place? 80% of the programs have been in place just less than 3 years. So you haven't missed the boat. It's still pretty early. Even a lot of systems that have tried their own programs. So there are a lot of systems that tried with some sort of video software, and then they got to the things we talked about earlier around next level thinking of platform, and then next level thinking of operational support. And now we're sort of coming back around to entities like ours going, okay, let's figure out the rest of what we need to do. So still very early there. who's in charge of the program? So 81% have a dedicated person. What we've seen really emerge as a best practice in the last year and a half is a director of telehealth. So people are now hiring formal directors of telehealth. A lot of times they are a nurse or a nurse practitioner, but they do not have to be, can be an administrator. And really they have to interact with business owners, have some interaction with technology, and then interact with the clinicians. That's their primary roles, but that's emerging as a best practice. And then they rank it as a high priority initiative the majority of the time, 83%. So typical system, less than 3 years in place, hiring someone at the director level to lead the program, and ranking it a high priority initiative. Lesson 9 is around market convergence. So the market and the markets that are converging together are really now redefining who a patient is and what their integration needs are. We previously, and we could have named the side, integration matters and you have to do it. Frankly, that's table stakes at this stage. We're way past it. What's more interesting is that how these markets are converging is now redefining data and experience for the patient. So as employers around the patient dial, you've got employers, health plans, and providers. You're seeing the merging of these markets. You've got payviders, where payers and providers are merging together, and employers now are looking into employee health programs and having clinics, and providers and managing their risks. And so there's a blending of here. But historically, they've each had different data, ways they look at data. So on the health plan side, real-time exchange is key, claim submission is key. These are year-to-date, none of these things are typos. So we do 400,000 RTE checks a month. We've processed over 427,000 claims this year. As you look at providers with ePrescribe, 43 million data elements we've exchanged. Those are not prescriptions. Those are elements for a prescription. Just to be clear, it's not that we've done 43 million prescriptions this year. And about 21,000 clinical consult records. So really expanding our capabilities there with electronic health record integrations. And then on the employer side, they look at membership and membership attribution through eligibility files. So 70,000 eligibility files year to date, and over 3.5 million members through their 834 files. So orders of magnitude for how much data we're exchanging, but we've got information on the patient from these different areas. So it's becoming less linear and siloed. So a patient could be coming in from an employer in Dell in Texas. They'd be coming in through an Aetna plan membership or through Memorial Hermann. And we were able to at least have some data on them in some capacities. And if you think forward-looking, next generation, if we start to incorporate marketing data on, did they actually pick up their prescription, and are they shopping for healthcare benefits, and is there a way to prevent an illness? The convergence of these markets and the ability to grab data from different sources, I think, is really neat and something very, very strong for this industry. And last, lesson 10 is that patient demand and market demand are driving additional capabilities. And this is somewhat of a historical slide, but to give you an idea of where things have gone and where they're going. So if you look at capabilities on the bottom of the slide, so I'm going to take you through the lower part of the slide. Teladoc very much started, and the market started in general medical care, right? The lumps and bumps that would go to the urgent care center, and how do we treat patients, and do we have provider networks, and how do we interact with people? And we built pediatric networks as well. And that's where, if you go from the bottom of the slide to the top, where, my child woke up with a fever, can I have 24/7 access to care? Then we start to add in additional networks, dermatology and behavioral health. Those were capabilities we added because the market was asking us for. We thought behavioral health would be a natural fit. Here I want to address my anxiety. So additional network capabilities were built. As those network capabilities were built, the integration needs and the devices came. So electronic health records integrations and building in devices, and then how do we do lab testing? And those capabilities opened up new use cases for the market. So in the middle, where you've got a natural disaster, very proud of our company that we were able to service a lot of people this year that were displaced by those unfortunate national disasters that we all heard about. I'm very proud that we stepped up as a company to help these folks that had been displaced. And then having abdominal pain, so in the provider space, we see clients that with a little creativity are now managing much more than just cough and pink eye and simple things. They're looking at abdominal pain and fractures, because in their mind, what telehealth does is allows you to get to an actionable decision point, and in lieu of a telehealth visit, no visit is much, much worse. So that's a great use case. And then with our acquisition recently and merger with Best Doctors and bringing in additional critical care and treatment capabilities, certainly cancer and complex care and all these very complex illnesses we're able to take care of. And all these additional capabilities now are really driving towards post-hospitalization care. So one of the fastest growing use cases in our market is post-surgical care, right? Instead of dragging the patient over who's just had a wound, who needs a wound check after their surgery, instead of dragging them and sitting in a car for an hour, it's in a waiting room, doing a wound care remotely, by the way, with multi-party video, being able to bring in specialists and subspecialists, and then the ability to add in lab, radiology, surgical consults, and other things opens up all sorts of additional capabilities. So our capabilities have grown as the market has asked us to build them, and as we build capabilities, additional use cases and market needs have developed. So a little bit of sense there as to, and insight into how we've grown and how we've grown as a company. So with that, we've gone through our 10 lessons, and I think at this point we're ready to open it up for Q&A. So back to you, Molly. I think you're going to be our moderator for questions, and then I'll go ahead and respond.
That's right. Thank you so much, Dr. Roga. That was a fantastic presentation. So like Dr. Roga said, we're now going to begin today's question and answer session. Please submit any questions you have by typing them into your control panel. There's a space labeled enter a question for staff. You can type them in there and then click send. We're going to try and get through as many questions as we have time for today. I also want to make note that we'll be sending a copy of the webinar recording to all registrants within a week. But if you would like to receive the presentation slides, please email providermarket@teledoc.com. So Dr. Roga, some questions did roll in while you were speaking. One of them here is, what percentage of clients use their own providers versus teledoc providers? Does this vary by hospital use case?
So as we work with employers and payers, the overwhelming number of those are using our providers almost exclusively. What we're seeing is it does depend on use case and the segment. So again, employers and payers overwhelmingly use only our providers for general medical care, behavioral health, dermatology, and the subspecialties we provide. In the hospital and health system space, it really is use case dependent. And it's very typical for the typical hospital that is doing general medical care, so acute care, will use our providers early on, because we're servicing, again, 5,000 to 6,000 patients a day. So for us, we're very flexible in that network setup, and we're frankly agnostic to whether they want to use our doctors or not. So if a hospital system wants to launch, virtual urgent care, general medical care, they will often start with our providers, and then as their programs get busier, phase them out. That's for the general medical use case. That's somewhat in contrast to when a hospital system is looking at post-surgical care, because they're in a readmission payment bundle anyway. So it's their surgeons and their specialists and subspecialists interacting with their patients. But well, that was pretty interesting to us, because early on, a lot of the hospitals seem to want to only use their doctors. And what we're finding is it's use case dependent. And when it's general medical care, they really are relying on our providers. Their primary care doctors are pretty tapped, and waking up at 2 o'clock in the morning to do a general medical care while they've got a full office the next day isn't necessarily what they want them focused on. So hybrid model is very common, use case dependent, and segment specific.
Great, thank you, Dr. Roga. This next question digs a little deeper into telehealth in hospitals too. How is telehealth being applied in a hospital setting? Who is generally in charge of managing the telehealth program? Is it a physician or administrator on average?
So what's really key to understand in the hospital setting is to understand the value drivers. So I'll start with that one first, and then I'll go into really who is owning the program. But the value drivers and the buckets of creation really are in three areas. They're around finance, they're around access to care, and then they're ultimately around market share and growth strategy. And each of them have different use cases. So on the finance side, this is anywhere where the system has financial risk, even as simple as being a large self-funded employer, but they've got an ACO, they've got a pop health program, readmission payment fund, those anywhere where there's dollars at risk, there's a immediate and demonstrable return on investment year one in consumer telehealth. On access to care, this is where they want virtual practices, so their providers seeing their patients virtually, balancing resources between facilities, so specialists might be at one hospital and they have to consult another one, graduate medical education training, and getting that data integrated into their EHR. And then the last one is a growth strategy, and that's ultimately around grabbing market share and really new patient acquisition or retention of existing patients. I would say that, as I indicated earlier, the second sort of biggest opportunity mistake I see is underestimating operational support, and this is the first one, which is the most successful programs look at telehealth as a tech-enabled service model that is an extension of their organizational goals. And when it lends itself to what the organizational goals are, programs are very, very successful. And in fact, it's so important, we've developed a proprietary readiness assessment tool that we help our clients build their strategic plans for their programs. The second part of the question, which was around who runs the program, whether it's a physician, non-physician, or administrator, we see a little of all of that. I would say, as I indicated a little bit earlier, best practice has emerged as having a formal director of telehealth. That director usually has some clinical acumen, usually either a nurse or a nurse practitioner that can understand the business needs and interact with the providers. So especially for larger systems, that's often an important role to have in place because they tend to grow their use cases. But I would say, as far as who is the main owner of the program, so the director level is usually the person who's in charge of the operations of the program, and then the main sponsor is often an administrator, usually in charge of strategy, because this is often a strategic discussion, but population health and occasionally marketing do come into play, or the C-suite. And there always is involvement with the physician leadership. So a typical hospital process includes, an executive sponsor of some sort, and then they want to have physician buy-in and leadership involved. So there's vetting of protocols, there's vetting of quality, there's vetting of the experience. And then the third path is often around technology, making sure the data is safe, it's secure, you do security audits and reviews, and how's data exchange, how's it going to be integrated. So those are pretty typical paths, but I would encourage everyone on the line, especially with large organizations, we've seen director level engagement be really key to success.
Okay, great. How about this next one is, in your platform, can your providers order labs and radiology tests, or is it strictly just prescriptions?
Sure. So yes, lab and radiology services are capabilities on the platform, and prescriptions, of course, have always been there. Why lab and radiology have been of importance is because we've seen a lot of those capabilities evolve and the needs evolve. So, the market has asked for additional use cases, and again, we're seeing a lot of it on the system dependent. So going back to their organizational strategy, some systems are very much focused on consumer acquisition. We have a large academic medical center. Their goal is 300,000 new patients within the next 3 years for their telehealth program, and we're helping them build that. Other organizations, 90% of their visits are scheduled visits, and a lot of those are surgical care, post-surgical care. So that's where lab and radiology services are a little more relevant. We offer that for internally in the system, so that's for their providers to order predominantly, because they're already seeing their own patients. And that's just, again, another example of how working with our partners and hearing what their needs are allows us to expand our capabilities to meet their use cases.
Okay, hoping to get to a couple more here if we have time, Dr. Roga. This next one is, if reimbursement is still lagging, how does Teladoc achieve its revenue goals?
Yeah, so the reimbursement aspect, to highlight it, and we spent a little time in on the regulatory slide as well, there are plenty of ways to get reimbursed and get paid in consumer telehealth. What is important thinking to understand for a lot of the providers on the line is that the traditional sort of commercial retail model of, a patient walking into the clinic and having, one of the major payers and having an in-network benefit and pulling out their insurance card, that market is not there yet for telehealth, right? There are only a few states that have true payment parity, and there are plenty of systems that are actively working with their local payers to, transform the coverage parity into payment parity for their system. And there's lots of them that we're helping and working with on. As far as our revenue goes, a lot of the revenue comes from self-funded employers and from direct relationships with the insurance carriers for populations that we serve. And then there is clearly a third area around direct-to-consumer programs, which a lot of hospitals seem to gravitate towards. So they put a branded platform out there with $49 a visit, upwards north of that in certain markets, and are driving adoption to their doctors and their platform for sort of a self-pay direct-to-consumer type model. But as far as revenue numbers, I mean, like I said, we'll do $230 million we projected for this year, and the bulk of that is in the self-funded entities and plan sponsors, and really very little on the sort of commercial retail type programs that a lot of hospitals are looking at.
Okay, great. Well, you know what? It looks like we are about out of time today. So I want to thank you, Dr. Roga and Teladoc, for what was an excellent presentation, and to our audience for participating and sharing your questions with us. We really appreciate that. Hope you all enjoy the rest of your day, and we look forward to having you join us for future webinars. Thanks so much.